Welcome, and thank you for joining the Society of Thoracic Surgeons Legislative Fly-In Briefing webinar. This presentation will provide background information to prepare you to engage members of Congress and their staff members during the upcoming legislative fly-in. My name is Courtney Yo. I'm the Director of Government Relations for the Society of Thoracic Surgeons. I'd like to introduce my colleagues, Josh Krantz, our Political Affairs and Advocacy Manager, and Madeline Sterling, Government Relations Assistant. Madeline will be speaking with you later on in the presentation. On behalf of all of us, I want to thank you for signing up to participate in the fly-in. I hope you will find this a rewarding and educational experience, and that you will gain tools today that will help you to develop relationships with your congressional representatives that will serve you and STS for many years to come. For those of you who haven't participated in a fly-in before, not to worry. Over the next 30 minutes or so, I will be joined by Dr. Frank Nichols, Chair of the Workforce on Coding and Reimbursement, and Dr. Shanda Blackman, a member of the STS Board of Directors. Together, we will walk you through a number of policy issues that are important to STS. We encourage you to take notes and review the briefing materials emailed out to you with this presentation. On the day of your Hill meetings, you can count on being teamed up with other STS members so you can share the talking points and focus on the things that matter most to you. Before we get started with the advocacy briefing, let's take a quick look at the schedule for the day. We'll see you next at breakfast at the Renaissance Hotel on Monday, October 17th. There you will receive your schedule of meetings on Capitol Hill. Some of you have ACS Clinical Congress events in the morning, and others will go straight to your first meetings on the Hill. At 11:30, STS is hosting a congressional briefing at the Capitol Visitor Center. We hope you will join us to educate congressional staffers about the value of the STS National Database. The rest of the day will be meetings on the Hill. Importantly, if you're planning to leave before 5 o'clock p.m., please make sure to communicate your travel plans to Madeline as soon as possible. Her contact information can be found at the end of this presentation. Together with Drs. Nichols and Blackman, we will walk you through the following topics: the current climate on Capitol Hill, the Medicare Access and CHIP Reauthorization Act, or MACRA, and proposed cuts to reimbursement for lung cancer screening. Finally, we'll explore the STS Political Action Committee and advocacy resources, and how they impact policymaking at the federal level. When preparing STS members for Capitol Hill visits, I always like to describe the climate you'll be heading into when you get to Washington. From stalled negotiations on the 21st Century Cures Bill, a landmark piece of legislation promoting medical innovation, to Zika funding wrapped up in Planned Parenthood politics, partisan gridlock is once again freezing Congress. Typically, Congress does not pass important legislation in an election year. Party leaders intentionally reduce the legislative work schedule to allow members ample time to campaign for re-election at home. The lame duck session, which is roughly the 2 months bookended by the November election and the start of the new Congress in early January, is often accompanied by a surge of activity from lawmakers who are freed from the specter of an upcoming election. However, sometimes activity in the lame duck session stagnates as policymakers set their sights on leveraging the political dynamics of a new session of Congress. That said, work we do in the present can often bear fruit in the future. It's important to recognize that our advocacy efforts do not have to ebb and flow along with the pace of work in Congress. So let's get started on MACRA. The most important acronym in healthcare policy in the last 2 years, and likely for many years to come, is MACRA, the Medicare Access and CHIP Reauthorization Act, signed into law in April of 2015. MACRA overall represents the culmination of more than a decade-long effort to repeal the flawed Sustainable Growth Rate, or SGR, the blunt instrument that was intended to keep aggregate healthcare spending growth in check. The MACRA legislation marks a major step towards moving us away from fee-for-service medicine and toward a system that rewards physicians for the quality of care they provide. It streamlines existing reporting programs like EHR Meaningful Use and the Physician Quality Reporting System into one new program called MIPS, the Merit-Based Incentive Payment System. Most importantly for cardiothoracic surgeons, MACRA incentivizes the development of alternative payment models, or APMs, and preserves the 10 and 90-day global payment structure. Another win for STS advocacy efforts over the past few years, and something we'll talk about more in a moment. Starting in 2018, physicians will choose whether to be paid through MIPS or an APM, both of which will expose physicians to both upside and downside risk. MIPS more closely resembles the current Medicare fee-for-service payment paradigm, while the stated purpose of an APM is to help physicians to increase quality of care while reducing costs and resource use. The MACRA drafters clearly preferred to nudge physicians into APMs, and the incentives are set accordingly. A 5% bonus will be awarded to physicians participating in qualifying advanced APMs, and those physicians will not be subject to MIPS measurement. Although we hope that APMs will eventually be the preferable path for STS members, MIPS improves on the incentive payment program ecosystem by consolidating disparate programs into one. The Physician Quality Reporting System, Value-Based Payment Modifier, and EHR Meaningful Use programs are streamlined through MIPS. One aspect of MIPS not listed here is a new reporting program for clinical practice improvement activities. More information on the specifics of all of these programs will be available in November. Unfortunately, reporting under the MIPS program will begin in January 2017, just 2 months later. Which brings us to our first set of asks for your meetings on Capitol Hill. An ask is what you're actually asking your members of Congress to do for you. Sometimes the ask can be supporting a piece of legislation or signing onto a letter from Congress to an administrative agency. Our advocacy efforts on Capitol Hill related to MACRA at this point in time are broad. We want Congress to keep an eye on the implementation of MACRA, so as complicated regulatory issues arise, we will have set the stage to influence those regulations through congressional action. At this point, I'm going to turn things over to Dr. Frank Nichols, Chair of the STS Workforce on Coding and Reimbursement, to talk you through our specific asks related to MACRA implementation.
Thank you, Courtney. Before continuing, however, I'd like to take a minute and thank each of you for your time and effort on behalf of STS and its membership. I've attended several of these legislative fly-ins and found them to be a very valuable learning experience. I learned that for the most part, the legislators you're going to be visiting with and their health policy staffs are truly interested in our thoughts and opinions. They're interested because we too are their constituents, as well as the broad base of constituents they represent. They're interested because ultimately they realize we are the individuals having to live with and practice under the results of the legislation they've created. And until widely vetted, there certainly can be unintended consequences or misinterpretations of their legislative intent. When it comes to the ask, I at first was nervous and skeptical. I quickly learned that I did not have to be. Really, I was there to inform and educate them about our viewpoints on these issues, and found almost all of those I met generally interested in our requests or asks, and very reasonable. Now for our asks. Our first ask pertains to the MIPS program that Courtney described. Specifically, we want to thank our Congress for the pressure they put on CMS to relieve some of the more immediate reporting burdens placed upon us. We, however, also want to ask them to continue to pay attention as the program rolls out. The second ask is for Congress to help STS with developing an APM. Although the legislation sets a pretty clear pathway for physician involvement in APM development, CMS, the agency in charge of Medicare, doesn't seem to want our input. Finally, we are asking Congress to hold CMS to the letter of the law in implementing a specific provision in MACRA that requires the agency to collect data on the postoperative care provided during the global surgical payment period. On April 27th of this past year, CMS released 962 pages of draft regulations. STS had several serious concerns with the proposal. STS and many other physician groups submitted comments to reflect these concerns, principally the timeline for MACRA implementation. As Courtney mentioned, 2017 is the first year performance measurement, yet the final rule is not expected to be published until early in November, leaving less than 2 months for physicians to navigate a submission process that hasn't even been created or released yet. Congress has heard our concerns, and several key committees have held hearings regarding problems like the proposed timeline. CMS has made the timeline more flexible. Recently, CMS announced that it will allow providers to pick their implementation pace. During 2017, eligible physicians and other clinicians will choose one of 4 options for participation. This includes testing the payment option, participating for part of the calendar year, participating for the full calendar year, or joining an advanced alternative payment model. Choosing one of these options will ensure a physician does not receive a negative payment adjustment in 2019, according to CMS. These options will be more fully described in the final rule, due to be released on November 1st. If the details of the revised rollout do not meet our needs, we'll need to go back to Congress for immediate relief. Meeting with your members of Congress now will help set the stage for that request if the time comes. Including in your briefing packet, you will find STS's comment on the proposed regulations implementing the MACRA statute. I encourage you to review this and other resources given to you before you come to Washington. You will find it quite helpful. Our second ask on Capitol Hill is that Congress provide assistance with APM development as they did with the MIPS reporting timeline. STS must ensure that the APM development process to which the Society is dedicating significant resources, both time and money, ends up not being an exercise in futility. Additional letters from Congress and hearings may be required to ensure that MACRA has the effect that Congress intended. While this action item does not come attached with specific legislation or a sign-on letter, it is still incredibly important for constituents to keep this issue on their representatives' radar. CMS has stated that their goal is to eventually transition all physicians into APMs, but the process by which the agency will get there and the extent to which they will involve physicians in this process is less clear. MACRA included a pathway for physicians to help in the development of APMs. This pathway designated a new type of APM called a Physician-Focused Payment Model, or PFPM. STS has been actively working on a PFPM proposal since 2013. We have recently joined with the American College of Surgeons to help them design a bundled payment methodology that can be used across all of surgery. Unfortunately, CMS does not seem to want to listen to our ideas. In fact, while we were working with ACS on a bundled payment methodology that could also use the STS National Database as a platform for quality improvement and shared savings, CMS released a proposal for a mandatory bundled payment for CABG. Participants in the CABG bundle will be selected by CMS later this year. Although physicians participating in the bundle have the opportunity to receive bonus payments for participating in an APM, many questions remain. We regret that CMS proposed this mandatory payment model without soliciting our feedback because we think that the PFPM proposal we are working on in collaboration with ACS will have more meaningful results for patients and will be less burdensome on cardiothoracic surgeons. Therefore, we are asking you to make your members of Congress aware of these concerns so that we can go back to them if we need to after the final MACRA regulation is published in November. Also in your packets you will find STS's comments on the CABG mandatory bundle as well as other materials on APM development. Our third ask is that Congress keep an eye on CMS as it publishes its 2017 Physician Fee Schedule Final Rule, which is also expected to be published in November. We may ask Congress to step in if nothing has changed with regards to global surgical payment data collection. We indeed may need legislative support to ensure CMS follows the congressional intent of MACRA. As you know, Medicare pays surgeons and other specialists a single fee when they perform complex procedures such as heart surgery. This payment covers the cost of the surgery plus all follow-up care within a 10-day or 90-day time frame. The surgeon gets one payment and the Medicare beneficiary only pays a single copay. In the 2015 Medicare Physician Fee Schedule Final Rule, CMS included a policy that would have eliminated these global surgical payments, requiring surgeons to bill for each individual service provided in the post-op period. STS fought hard against this proposal because we felt it would fragment patient care and impose a significant administrative burden on physicians and their staffs. Congress agreed with us and overturned CMS's policy. Instead, the MACRA legislation required CMS to collect data starting January 1, 2017 on both the number and level of visits furnished by providers during the global period. Specifically, Section 523 of the MACRA policy explicitly calls for CMS to gather information needed to value surgical services from a representative sample of physicians. And I stress it says representative sample of physicians. Despite this congressional mandate in the proposed rule for the 2017 Medicare Physician Fee Schedule, CMS announced its plans to collect data for all 10 and 90-day global surgery services from all physicians who perform these services rather than from the required representative sample. And if that isn't enough, CMS also proposed that surgeons report this information by recording an entirely new set of G-codes that must be submitted on their claims, these G-codes reflecting care provided by providers in 10-minute increments. CMS's proposal is problematic for many reasons. First of all, the scope of the data collection far exceeds the data collection that MACRA authorized CMS to carry out. Requiring all physicians to report is an overstep of the statutory direction given to the agency by Congress. Secondly, the proposal requires all surgeons to submit data in 10-minute increments of time for all 10-day and 90-day global surgery code services through the use of 8 non-payable G-codes. It is not likely the data reported back to CMS will accurately portray all the post-operative surgical care that is provided under the existing bundles. These G-codes do not yet exist. If finalized, the data that will be generated through the use of the proposed G-codes is unlikely to actually provide the agency with the data it needs to accurately value these codes. Finally, the proposal will impose an undue administrative burden on physicians. Utilizing published annual Medicare utilization data, it has been estimated that nationwide there will be 316 million new G-code claims. This equals the most recently available number of independently billed E&M claims of 316.5 million. At 5 minutes of physician time per code, that would equate to 26 million working hours for providers. A truly staggering number. The simple reality is, this undue administrative burden on physicians will disproportionately direct provider resources towards compliance and away from important patient care. This is also at a time when many physicians are scrambling to understand and meet the other new requirements of MACRA. Mandatorily requiring physicians to account for every 10 minutes of their time during the global period will directly harm patient care. The proposed rule is in direct contradiction to both the letter of the law and congressional intent. As such, STS and other surgical specialty groups have been tackling this highly burdensome proposal head-on. Over this past summer, STS sent a grassroots alert out to all of its members, asking them to contact their representatives in Congress. Two of our best congressional allies, Dr. Ami Bera and Dr. Larry Bouchon, initiated a sign-on letter to CMS asking the agency to rethink its proposal and comply with the congressional directive included in MACRA. As a result of our advocacy efforts, 112 members of Congress have signed this letter. For comparison, just 53 members signed the 2015 congressional sign-on letter to protect global payments from being entirely dissolved. This letter demonstrates that STS members and others have effectively educated members of Congress on the importance of global surgical payments over the last few years. Multiple STS key contacts have also met with their members of Congress at home in their districts to highlight this issue, and hopefully you too will bring it up with your members on October 17th. Once again, we provided a number of materials to help you make this case. Included is the congressional sign-on letter that was sent to CMS last month. Now we're going to switch gears a bit and talk about a patient advocacy topic, lung cancer screening cuts. Dr. Shanda Blackman is here to discuss this issue.
We were just discussing issues with the 2017 Physician Fee Schedule proposed rule. Another rulemaking from CMS, the 2017 Hospital Outpatient Prospective Payment System proposed rule, or HOPS, also contains troubling items, such as cuts to lung cancer screening reimbursement. And that is why we'd like to ask Congress to help us if CMS goes through with these cuts. If the HOPS proposed rule is implemented, reimbursement for CT lung cancer screening, shared decision-making sessions, and low-dose CT lung cancer screening will be reduced by 64% and 44% respectively, in comparison to 2016 payment rates. STS and others are deeply concerned about the impact of these reimbursement changes on patient access to lung cancer screening. The Society of Thoracic Surgeons and others have asked CMS to rescind these damaging cuts and to retain the current structure of the various payment classifications as established in the 2016 HOPS final rule. More than 200,000 Americans are diagnosed with lung cancer each year, resulting in more than 157,000 annual deaths from this disease. Lung cancer remains the most deadly form of cancer in the United States, killing more people than breast, colon, and prostate cancer combined. Lung cancer can often be successfully treated if caught early, but patients don't typically display symptoms of this disease until the cancer is in its most advanced stages. Federal policies that promote low-dose CT screening of at-risk populations are crucial and have increased over the past few years. In December 2013, Congress helped expedite a favorable recommendation from the USPSTF. The final recommendation called for low-dose CT screening of current smokers aged 55 to 80 years who have a smoking history equivalent to a pack a day for 30 years or 2 packs a day for 15 years. STS advocated heavily for Medicare to cover the screenings as recommended. Private insurance plans had to cover lung cancer screening by January of 2015. However, Medicare was not required to follow the USPSTF recommendation. Instead, CMS was encouraged to analyze the service and then make a national coverage determination, also called an NCD. The NCD process did not result in Medicare coverage. However, after further advocacy efforts, such as the STS 2014 summer fly-in, during which low-dose CT screenings were featured as the main ask, CMS finally ruled in February of 2015 that screenings would be fully covered. Annual low-dose CT scans have been found to be more or equally cost-effective than other accepted cancer screening interventions, including breast, cervical, and colorectal screenings. Additional studies have indicated that lung cancer screening, shared decision-making sessions, which encourage tobacco cessation for those individuals still smoking, can further increase the cost-effectiveness of lung cancer screening with cost benefits to CMS in treating other diseases. CMS's proposed rulemaking is a marked departure from the recently expanded access to annual low-dose CTs. If the reimbursement rates for shared decision-making visit and corresponding low-dose CT scan are too low, it will be cost-prohibitive for hospital outpatient departments, and many will not be able to afford to offer these services at all. Qualifying patients will be unable to receive annual screens, and the battle to combat lung cancer mortality will be severely undermined. This reality is especially troubling considering that numerous hospitals are just beginning to offer annual low-dose CT services. These cuts will undoubtedly have the greatest negative impact on the underserved poor and minority patients due to their reliance on hospital outpatient departments, located primarily in inner cities or facilities that serve large geographic areas. In addition, the underserved poor and minority patients are some of the most vulnerable populations with the highest rates of lung cancer mortality. While undoubtedly unintended, CMS cannot ignore the inherent inequitable impact of these proposed cuts. Ultimately, we hope CMS has heard us on this issue, and it will be resolved in the final rule. While you're meeting with your representatives, please consider asking them to keep an eye out for the HOPPS or the HOPS final rule in November and prepare to step in if necessary. We cannot afford to undo so many years of progress in this area. Your briefing packet contains several resources on this subject, as well as including STS's comments on the HOPS proposed rule and a sign-on letter that was co-led by STS and signed by 85 different healthcare entities. Now, Madeline Sterling is going to go over some of STS's policy victories that fly-in participants like you helped to accomplish, along with the impact of the STS-PAC and advocacy resources at your fingertips.
Thanks, Dr. Blackman. This slide provides an overview of some advocacy successes in the past few years. STS has gotten big wins on TAVR, lung cancer screening, SGR repeal, and the preservation of both global surgical payments and crucial research funding that many STS members rely on. These efforts tend to have long time horizons and sometimes require constant diligence, as you have heard today with lung cancer screening and globals. There aren't always flashy pieces of legislation like MACRA to celebrate. Sometimes victory means CMS leaves something out of a final rule. But I think everyone would agree that the results are worth the work. How else can STS influence these important policy decisions? The composition of Congress matters when it comes to drafting effective public policy. It's important to ensure that the physician community at large, and cardiothoracic surgeons specifically, are both represented in and heard by Congress. STS-PAC works toward that end. As the political arm of the Society of Thoracic Surgeons, the PAC, or Political Action Committee, allows cardiothoracic surgeons to participate in politics and make STS's voice heard. The PAC helps elect physicians and other allies of our specialty to Congress. The PAC exclusively supports candidates for federal office and does not get involved in presidential elections. Contributing to the PAC is one way to be an advocate, as is attending a fly-in. Hosting a site visit is another great opportunity to forge a personal connection with your member of Congress. We arrange all the details and you run the show, educating your representative with a hands-on and lasting experience. As always, please use the STS Advocacy website as a resource. You can sign up to be a key contact, stay abreast of developing policy issues, contribute to the PAC, and more. Many of you attending the fly-in are key contacts. If you're not already an STS key contact, it's easy to sign up online. Key contacts are cardiothoracic surgeons on the front lines of advocacy efforts throughout the year, committing to at least one advocacy activity per year, our go-to team of advocates for the specialty. Key contacts are the face of STS relations with Congress. We also encourage you to follow advocacy developments through our various email newsletter publications. If you have any questions regarding the upcoming fly-in or anything to do with politics and policy, please do not hesitate to contact the STS Washington office staff. We very much appreciate you taking the time to familiarize yourself with these issues. Thank you for viewing this webinar, and we look forward to seeing you in Washington, D.C.